Good morning, good afternoon, or good evening, wherever you are. My name is Dr. Samden Lhatoo. I'm an epilepsy specialist at the Texas Comprehensive Epilepsy Program in Houston, Texas. And I'm here today to speak to you about the consequences of uncontrolled epilepsy. In particular, one catastrophic outcome of uncontrolled epilepsy, which we seek to avoid in our patients. The consequences of uncontrolled epilepsy are varied and impact many people who suffer from this condition. There's a risk of other diseases and conditions that arise from the seizure disorder. People suffer from poor physical health that may be seizure-related or medication-related. Epilepsy and seizures, particularly uncontrolled seizures, often have an impact on an individual's psychological and emotional health. And of course, seizures, particularly generalized tonic-clonic seizures or grand mal seizures, often result in injury. These may be injuries because of falls, they may be injuries sustained because of whatever activity the patient engaged in during the time of the seizure. And of course, things like tongue biting, carpet burns, and so forth are very common. Uncontrolled seizures also lead to socioeconomic problems, job losses, limitations of employment, and similar consequences that arise from ongoing seizures. One of the most important consequences of uncontrolled epilepsy is the risk of mortality. We've known about mortality due to seizures for a very long time. So this is a cuneiform tablet from the Akkadian civilization from several millennia ago. And here there is a very detailed account of a patient who suffers from uncontrolled, prolonged seizures that eventually lead to death. There has been some confusion amongst specialists in neurology and in epilepsy over the years. So there was one individual who said the danger to life of patients is not actually all that great. And another specialist, equally well known, who said that the life expectancy of a patient with epilepsy actually does not reach that of the average person. The person who said the former was William Gowers, a very famous neurologist who's considered one of the fathers of modern neurology. And the other, Dr. Rodin, at the Lafayette Clinic in Detroit, who was a very esteemed physician who looked after patients with epilepsy. We now know that the risk of mortality in patients with epilepsy is actually 2 to 3 times greater than that of somebody out there in the general population. So epilepsy-related deaths may be because of sudden unexpected death in epilepsy, a very enigmatic phenomenon that we seek to study and prevent. Status epilepticus, which is a situation where there is a very prolonged seizure or series of seizures that ultimately result in death. There may be accidents, falls, and so forth. Some patients develop pneumonia after seizures because of aspiration of food or stomach contents going into the lungs. Some patients have drug toxicity and side effects that cause mortality. There are others who suffer from extreme depression and have a tendency to suicide, and some of these eventually may be successful. There are underlying diseases that may be related to death. So brain tumors, for example, cause both seizures and contribute to mortality statistics. And there are other things that epilepsy patients may also be prone to, such as ischemic heart disease, pneumonia, and accidents unrelated to seizures. So I will talk now more about this phenomenon of sudden unexpected death in epilepsy. You may be surprised to know that one of the first accounts in literature actually was provided by George Washington, whose stepdaughter suffered seizures and in fact died in 1773 after a seizure. And George Washington wrote in great detail about it. Neurologists and scientists were a little slow to catch up. And so the first account of a proper study of Pseudodeath was in 1975, where 37 cases were studied. It was a couple of decades later that we agreed upon definitions. In 2013 came out one of the most important studies, Pseudodeath, referred to as the Mortimer study, or the mortality in epilepsy monitoring units study. And in 2015, the National Institutes of Health, the NIH, invested a considerable amount of money for Pseudodeath research. And you'll be hearing about some of that research during this particular talk. So it wasn't just George Washington. In the literature and in the news, you may have heard of other folks who died or very nearly died from seizures. So Lil Wayne at one point was hospitalized with seizures, and he said that he had 3 of them in a row, and on the 3rd one, his heart rate went down to like 30%, and he very nearly died. And that is actually a description of what actually happens in some people who die of Pseudodeath. So what is Pseudodeath? How is it defined? It's a sudden, unexpected, witnessed or unwitnessed death. It is not due to trauma, and it's not due to drowning. It's not due to prolonged seizures. And of course, in postmortem examination, we find no other explanation for death. So this is a very mysterious, enigmatic phenomenon where during or after a seizure, a patient passes away because the brain shuts down and does not support breathing or cardiac function. Depending on what we find in the autopsy, we might call it a definite Pseudodeath, a probable Pseudodeath, or a possible Pseudodeath. So what you see in the bar graph in the lower left-hand corner is the age distributions in which Pseudodeath occurs. And you'll see that the majority of those who are between the ages of 20 and 50. So this often happens to folks who are in the primes of their lives, but it does affect any age group. So you could be very young or old, and Pseudodeath is still something that can happen, particularly in folks who have uncontrolled seizures. Happily, Pseudodeath is a relatively rare occurrence. It occurs approximately once in every 3,000 people with epilepsy. If it's uncontrolled epilepsy, it tends to be more frequent. So with frequent generalized tonic-clonic seizures or grand mal seizures, for example, we believe that the risk is probably 1 in every 200 or 300 people. And it's most likely to occur in those in whom no treatment has worked, sometimes not even epilepsy surgery. So as I said, grand mal seizures or generalized tonic-clonic seizures are a risk factor. Patients often have epilepsy that has started at a young age, and therefore patients have had epilepsy for a long time. Some studies have shown that males may be at slightly higher risk than females, and things that prevent proper seizure control, understandably, may increase risk. So taking medication is very important. Not taking it increases risk. Some things that make seizures worse, such as alcohol and drugs, those do not help the situation. And of course, it's very important to be correctly diagnosed because there are many types of seizures and many types of epilepsies to make sure that the treatment is appropriate. So what exactly is the risk afforded by generalized tonic-clonic seizures or grand mal seizures? Well, if a patient has, say, 3 or more grand mal seizures per year, as opposed to none per year, the odds of having a Pseudodeath outcome is approximately 15 times more. So you can see from this that grand mal seizures are a significant risk factor. So how does Pseudodeath occur? The short answer is we don't exactly know, but we have made many observations about what happens before and during the Pseudodeath phenomenon. So a grand mal seizure causes breathing to stop, and often this is followed or accompanied by heart rhythm stopping at the same time. It tends to happen more often at night, seizures that arise when the patient is asleep. There is usually nobody around to witness or observe the seizure. And we believe that if somebody's around and intervenes during or after a seizure, that possibly is helpful in preventing death. We don't completely understand why some people are at risk compared to others, but we believe that having long-standing epilepsy and frequent grand mal seizures damages certain parts of the brain that control breathing and that control heart rhythm. And in particular, I refer here to a part of the brain that's referred to as the brainstem. And I'll be speaking more about that in a minute. So here is a case of an individual who very nearly passed away in the epilepsy monitoring unit. So this is the brainwave recording, this is the EKG or heart rhythm recording, and this is the breathing recording. So at this point, this individual's seizures end, and you can see that this person has a combination of the heart not beating very well and the person not breathing very well. So this is what a proper breath looks like. You can see here the person has shallow breathing, no breathing, maybe a couple of breaths, and then no breathing again. And at the same time, the heart rhythm is doing all kinds of odd things. So how do we look for breathing problems and heart problems in the epilepsy monitoring unit? We use a variety of equipment. So this is referred to as the oximeter, looks at oxygenation. We put belts around the chest and the abdomen to monitor breathing. This also monitors breathing. In selected individuals, we look at continuous blood pressure recordings to see if blood pressure goes down. And again, in selected individuals, we look at what happens to carbon dioxide in the blood, because raised carbon dioxide in the blood is an indication that the person is not breathing very well. So I'm going to speak about a couple of things that we can observe in the epilepsy monitoring unit. One of these is called ictal central apnea. This is stoppage of breathing during a seizure. So you can see that an individual here is breathing away in the middle of a seizure, no problem. Here's another individual who has a certain kind of seizure start, and the person is breathing before the seizure, but when the seizure starts, the person's not breathing anymore. So the stoppage of breathing during a seizure, if you time it, and if you look at the level of oxygen, you can see that in the majority, the duration of the stoppage of breathing is not very much. And the extent to which the oxygen drops is also not very much. But there are some individuals that we see in this corner where the duration of stoppage of breathing is considerable and where the drop in oxygen is also considerable. And we believe that these individuals may be at risk of Pseudodeath. So why does a person stop breathing during a seizure? It's because the seizure discharge spreads to parts of the brain that control breathing, and the seizure effectively paralyzes breathing control. So here you can see that we've used brain mapping to identify those parts of the brain that stop breathing. So this is an electric current, a very small electric current that we pass in the brain to mimic a seizure. And what happens is a person who's breathing well suddenly stops breathing. When you stop the current, the person starts breathing again. And the current is being passed to exactly these parts of the brain that control breathing, thereby provide proof of their role. There's another kind of breathing dysfunction, and this is the breathing that I showed you in our patient who very nearly died of Pseudodeath in the epilepsy monitoring unit. So this is referred to as post-convulsive central apnea, or PCCA. And this is a little different from the breathing that stops during a seizure. We believe that if breathing stops after a seizure, that's even more dangerous. Now, that kind of breathing stoppage is because the brainstem, so this is the part of the brain that has a lot to do with breathing control and with heart rhythm control, those parts of the brain are not working very well. So some individuals have looked at giving patients a little more carbon dioxide in the air that they breathe to see what happens to their breathing. Because if carbon dioxide is increased in the air we breathe, we're supposed to breathe faster to get rid of that carbon dioxide. And we know that in seizures, carbon dioxide accumulates, and that accumulation is not good for us. So here we see one particular individual in whom we give more carbon dioxide, but it makes no difference to breathing. So in this particular individual, it means that the brain doesn't know how to get rid of carbon dioxide because the control centers are damaged. And we believe that these people may be predisposed to Seudodeath. Now, what is the chemical, or what is the molecule that helps the brain get rid of carbon dioxide? It's a molecule that's referred to as serotonin. And we know from studies we've done that patients who have breathing difficulties during or after a seizure, those are the same individuals in which serotonin levels are not very high after seizures. And we believe this is what predisposes to risk. Researchers have found that if we look at the MRI scans of these individuals using quite sophisticated techniques that we don't usually use in the hospital when we look at brain scans, we find that some individuals have damage in the brainstem that can be identified on brain scans. So obviously, this is damage that's not identified by routine scanning and takes quite a bit to be demonstrated. So this is work in progress. We hope one day that we'll be able to look routinely at the brain stems of individuals with MRI brain scans. The damage that I spoke of has been looked at in individuals who died of Seudodeath under the microscope. And indeed, the brain cells that produce serotonin seem to be less populous. There are less of those in individuals who've had seizures for a long time and died of Seudodeath. There's a very interesting phenomenon that occurs in the brain stems of mice. And these are mice that are specially bred and have seizures that end in death in these mice. And one of our colleagues, a very well-known researcher, looked at the brain stems of these mice and demonstrated a phenomenon called spreading depression, where the brain stem just shuts down and stops working. And so here you can see this is what's referred to as spreading depolarization, where there's a wave of a shutting down phenomenon in the brainstem that stops these mice from breathing. Now, is there a genetic risk with Seudodeath? There is actually no evidence that Seudodeath runs in families. There are certain genetic disorders where Seudodeath is a little more common, and indeed, there are some genetic disorders that also coexist in individuals who have epilepsy that can cause heart rhythm problems and death. And here in particular, I refer to a condition called the long QT syndrome, which causes rhythm disturbances in the heart, which are sometimes fatal. So what can we do for Seudodeath? How can we intervene, and where are we? So I spoke about serotonin. There's a possibility with a little more evidence that we can use medications that raise serotonin levels to prevent death. So one day, we hope that we will have enough evidence to run a clinical trial that uses such medications. Some things may be working, and this is mainly to do with spreading awareness of Seudodeath, both amongst patients and carers, as well as amongst physicians. We can see that over time, the incidence of Pseudodeath has actually gone down a bit. So this was a study that was done in New York, San Diego, and Maryland, where Pseudodeath incidences, so deaths from Pseudodeath, were studied over a period of time and found to go down. So acknowledging the problem, the Pseudodeath problem, is very important. This is acknowledgement in the epilepsy community, in particular among specialists and carers and patients. We've been a little slow on this. It was actually in 2003, just 18 years ago, that there was a guideline issued on Pseudodeath, where it was considered part of the essential information to be given to patients with epilepsy and their loved ones and their carers. And it was in 2012 that in America, the Institute of Medicine said that people with epilepsy and their families need complete and accurate information on mortality and in particular Pseudodeath. Unfortunately, and this is a study from some years ago, as I've said, things have improved, but perhaps not as much as we would like. You can see here that almost 75% of physicians who treat patients with epilepsy or brain disorders, so 75%, it's 33 plus 30 plus 12, these are physicians who sometimes, rarely, or never discuss the risk of Pseudodeath with their patients who have epilepsy. You can see that that's not a problem that's unique to America. The same happens in the United Kingdom and Italy and of course North America, that the majority of specialists don't discuss Pseudodeath. And part of the problem here is that some physicians themselves may not pay much attention to what we know about Pseudodeath. And so you can see from this particular study that how much a physician knows about Pseudodeath is related to how often they discuss Pseudodeath. So if a physician doesn't know much about Pseudodeath, you can understand that he's not going to talk about it very much. So these are issues that we're trying to address in our own community. Of course, patients and their carers would love to know about risk. So you can see here in a study of people with epilepsy that almost half the patients worry about mortality. And if you look at caregivers of people with epilepsy, 83% care about knowing about mortality and Pseudodeath. So researching the issue is important, and this is a very optimistic slide we see here. In the 1990s, there were not many studies on Pseudodeath. Now, in the 2020s, the number is exponentially higher, and this is in large part due to bodies such as the NIH and epilepsy foundations that support research, such as the Cure Epilepsy Foundation, all pulling together to fund Pseudodeath research. So what else about prevention? People have thought about the pre-seizure period, people have thought about the seizure period, and they've thought about the post-seizure period, where a lot of potentially dangerous stuff can happen. So the brain shutting down, breathing problems, blood pressure problems, heart rhythm problems. Some people do suffocate, and in some people, the throat can close up and prevent breathing. At this time, a lot of the effort has gone into detecting seizures so that carers can be warned that somebody's having a grand mal seizure. So this is the Speak Brain Sentinel device, which attaches to a patient's biceps, and it notifies designated caregivers about a seizure having occurred. And this FDA-approved device is something that's useful, and it was something that we didn't have before. There's another device called the Embrace device, which is worn as a watch. This looks at the relationship between sweating and skin changes and seizures. This is also FDA approved and can reliably detect seizures in many individuals. So these are devices that are available that may be proven in time to actually reduce the incidence of Pseudodeath. Unfortunately, there's no such thing as a perfect device right now. There are many devices out there. Only 2 of them are FDA approved, but all of them, whether they're FDA approved or not FDA approved, suffer from one particular problem, which is of false alarms. So this is where a seizure is not actually occurring, but the device gives off an alarm to the patient or to the patient's loved ones, carers, to say that a seizure is occurring. Of course, if this happens very frequently, it leads to a cry wolf kind of situation, which is not good. So these are all false alarms that these devices can cause. In the post-seizure period, that's a question I guess that get asked very often, which is, can we do something to prevent the heart stopping? Unfortunately, the defibrillator or pacemaker, or the stuff that we use to prevent cardiac deaths, these are not very effective in Pseudodeath, or unlikely to be effective in Pseudodeath. So I'm going to conclude here, and I will reiterate some of the important learning points of this talk. One, that Pseudodeath, very fortunately, is rare overall, but it can be more frequent in patients with uncontrolled epilepsy. So it's very important to pursue seizure freedom. It's important to get the correct diagnosis and therefore the correct treatment, and thereby lessen the chances of mortality. Pseudodeath occurs in all ages, but it's most common in the 20 to 50 year age group, and this is an important consideration. We believe, and you saw from some of the slides that I showed, that a particular part of the brain, referred to as the brainstem, is the part that's important, and if damaged by long-standing epilepsy and grand mal seizures, may be instrumental in causing death. There are devices out there, and these are mainly seizure detection devices. They may have a role in Pseudodeath prevention. We don't have direct evidence just yet, but if they are efficient at warning patients and carers about seizures, it improves the chances of us being able to intervene during or after a seizure to perhaps prevent death. And I emphasize here that at the moment, the best way in which we can prevent Pseudodeath is seizure freedom, whether it's through proper assessments, appropriate medications, or even epilepsy surgery and deep brain stimulation, all the things that are currently available. Achieving seizure freedom is the most important thing. The next most important thing, if seizure freedom is not possible, is reducing the number of seizures. So it's important that anyone who has uncontrolled epilepsy should see an epilepsy specialist. And I'll stop here. Thank you very much.